Good afternoon, everyone, and welcome. My name is Adrienne Griffin. I'm the Executive Director of Maternal Mental Health Leadership Alliance, and I welcome you to today's webinar on pregnancy, infant loss, and maternal mental health. We are so grateful to all of you for taking time from your busy lives to be with us here today. We've got a fabulous group of speakers, and we're going to be talking about a very, very important topic, a topic that may be heavy at some points during today's session, but a topic, of course, that impacts almost all of us, everybody that we know. Almost everyone I know, my mother, my sisters, my friends, we've all experienced a pregnancy loss, a miscarriage, and we just need to talk about it. And so that's what we're going to do today. So again, welcome. Today's webinar is on pregnancy, infant loss, and maternal mental health. We'd like to thank the California Healthcare Foundation for supporting this event with funding. We are so grateful to all of our partners in the maternal mental health field. So next slide, please. I know most of us are familiar with Zoom at this point, but just a reminder, at the bottom of your screen, please use the Q&A button if you'd like to submit questions. We'll have a good time for a good, robust dialogue at the end of our presentation. You can use the show captions button to see live captions and to share an emoji. Next slide, please. Again, my name is Adrienne Griffin, and I am the Executive Director of Maternal Mental Health Leadership Alliance, MMHLA. We are a small but mighty nonprofit, and we focus on improving the mental health of mothers and childbearing people in the United States by focusing on national policy and health equity. Next slide, please. And today's webinar is the third in a four-part webinar series that we are hosting this fall called Delving into Maternal Mental Health. Each of the four webinars takes on a particular topic, and we kind of do a deep dive with experts in that particular arena. And so we had a birth trauma webinar in August. Pregnancy and disability was our topic in September. Today, of course, we are talking about perinatal loss. And then in November, we will be discussing military mothers. And there is the link. And just as a side note, you'll be receiving all of these slides. So you'll have links to all of these different things, but we hope that you will come back and join us in November. Next slide, please. So today, here's what we're going to be talking about: an overview of pregnancy and infant loss. And then we will hear about some lived experience and then discuss strategies for what both employers and policymakers can do to support these issues, and particularly support bereaved parents. Next slide, please. And after this webinar, we will email you everything that you need: a brief survey, the PowerPoint presentation, and the webinar recording. And we will also be posting all of that information to our website so you can share with friends and colleagues. Next slide, please. So just a little bit moment on self-care. We know, again, that this can be a very heavy topic. In fact, we're probably going to pause at different times during today's webinar to give everybody kind of an opportunity to breathe, kind of settle in. And in fact, I'd really like to start with that. I know most of us have been racing around all morning. Maybe we just grabbed our lunch to join us. So maybe we could just all take a moment to just sit nice and tall in our seats. Maybe close our eyes and just take a nice deep breath in for a count of 3, 2, 1, and hold it for 4, 3, 2, 1, and then exhale for 5, 4, 3, 2, and 1. All right, so please take breaks as you need. And next slide, please. So I am thrilled to share our fabulous speakers. Today, we will be hearing from Kay Matthews, who is the founder of the Shades of Blue Project, a community-based organization in Houston, Texas. And Kay will be sharing her story about her daughter, Troya. Next, we will have Jessica Brooks Woods, who is a board member for MMHLA, and she is the CEO of the National Association of Benefits and Insurance Professionals, and she will be talking about potential strategies that employers can do to support bereaved parents. And next slide. And then finally, we will hear from Jamie Zalway Belcito, who is MMHLA's founder and currently serves as our Director of Policy and Partnerships, and she'll be talking about strategies for policymakers. Next slide, please. Okay, so to set the stage, I'm just going to talk through some key facts about maternal mental health. Next slide. Those of you who work in this field, this will most likely just be a refresher, but we know that 1 in 5 mothers and childbearing individuals are impacted by mental health conditions. In fact, they are the most common complication of pregnancy and childbirth. And tragically, we know that mental health conditions are the leading cause of maternal death, with suicide and overdose combined, being the leading cause of death for women in the first year following pregnancy. Next slide. We know that the cost is significant, $14 billion each year in not treating maternal mental health conditions. That's $32,000 per mother-infant dyad. We also know that the majority of people, 75% of those who experience maternal mental health conditions, actually remain untreated. That's what contributes to that high level of cost. Next slide, please. We also know that certain individuals are at increased risk for experiencing maternal mental health conditions. These include individuals of color, people who live in poverty, military service members and their spouses, and our veteran mothers. We also know that it is a wide range of illnesses. What we used to call postpartum depression, we know it's so much more than that. Oftentimes it's anxiety. It can be also obsessive compulsive disorder, post-traumatic stress disorder, bipolar illness. And we know these conditions often start during pregnancy. And so we'll use the term maternal mental health conditions. There are a variety of terms that are used in the field: perinatal mental health conditions, perinatal mood and anxiety disorders. But the idea is that these are illnesses that can start anytime during pregnancy and continue through that first year postpartum and include a wide range of mental health disorders. Next slide, please. So now a few facts and figures about perinatal loss, just to sort of set the stage so that we have a common vocabulary and just a high-level overview of sort of the prevalence and terminology. So next slide, please. So when we talk about perinatal loss, there are basically 3 different categories that are included. So first is miscarriage, which is defined as loss of a pregnancy less than 20 weeks gestation. And this we know is 10 to 15% of all recognized pregnancies, so people who recognize that they are pregnant, and as many as 30% of total pregnancies. So sometimes miscarriage happens so early that a person may not even realize that they're pregnant. So stillbirth then is the loss of pregnancy after 20 weeks gestation. Here in the United States, it's about 21,000 stillbirths each year. That's 1 in 175 pregnancies. And then there's neonatal and infant death. So neonatal refers to a baby who dies before 28 days of life, and that's 3.6 per 1,000 births. And then infant death is a broader category that includes neonatal, but then extends all the way through that first year. And you can see it's 5.4 per 1,000 births. Next slide, please. Of course, as with almost everything we learn about maternal mortality and women's health, Black women are 2 times as likely to experience a miscarriage or stillbirth as white women. For many of the reasons that we know, maternal preconception health, the lower socioeconomic status, which can lead to things like access to or inability to access quality health care. We know the intergenerational stress and trauma that takes a toll on Black women's bodies, causing them to age faster. And of course, we recognize racism and bias in the healthcare system. Next slide, please. So what is the impact on parents? Some of this is probably self-evident, but we wanted to put some words around it. We recognize that perinatal loss is most often unexpected and can be very, very traumatic. It can be emotionally devastating and life-changing. Some parents live with the memories of their child for the rest of their lives. And we know that parents who suffer perinatal loss, even if it's an early term miscarriage, suffer numerous losses. They suffer not only the loss of that baby, but the relationship with that child that they didn't even know that they imagined. I remember I had a very early miscarriage, and I still think about what that baby, what that person could have been like. Parents suffer the loss of safety, their trust in their own body. It can take a toll on their self-esteem and their self-efficacy, really calling themselves, their sense of self-worth and their sense of health into question. We hear women say, how did my body fail me at one of the most basic things that my body is supposed to be able to do? And they lose trust in the world as they know it. We think that it's easy to get pregnant, to stay pregnant, to have a baby, when in fact, as we've seen before, at least 1 in 3 pregnancies will end. Next slide, please. So bereaved parents feel a whole wide range of emotions: sadness, loneliness, emptiness, grief, yes, also anger and fear. And then I was really surprised in doing research for this webinar to learn that often these parents also feel symptoms of guilt and shame, self-blame, and again, that sense of failure. And we're going to dig into this a little bit when we talk to Kay and some of our other speakers. Next slide, please. And because of all that range of emotions, bereaved parents experience a wide range of issues. They often feel stigma and blame as if this loss were their fault. They feel isolation. People don't know what to say or do to help them. Sometimes they feel that they're being shunned, again, because people don't know what to say or do, and so they will circle around those bereaved parents. A loss of social status, relationship struggles. We see that perinatal loss can really impact the marital relationship as well as relationships with other children. And there are oftentimes financial issues as a result of some of these relationship challenges. Next slide, please. And so we know then that bereaved parents experience higher rates of mental distress, which makes complete sense, but that can impact their health as well. We see an increase in drug and alcohol use, higher rates of divorce, and problems with other relationships. And again, none of this comes as much of a surprise. Next slide, please. So what do bereaved parents want? I read many articles, and I sort of boiled it down to these 4 things. So they, first of all, want to acknowledge that their baby is an irreplaceable individual that has a name. And they often want people to use the baby's name. They want people to acknowledge their parenthood and validate their grief. We want to acknowledge their traumatic experience, as well as their need for specialized support. Next slide, please. And we hear from bereaved parents that they have 4 distinct needs. They need to be heard and to be held. They do not want to be silenced. They need to have access to bereavement services. They often want to make meaning of their loss and regain some sense of control. And again, you'll hear from Kay and from some others today whose lived experience propels them to be advocates in this sphere. Next slide, please. We've learned from a great organization called Return to Zero that bereaved parents often want to name their baby, rock, hold, and kiss, and cuddle their baby, take pictures. They want to have time to hold and be with their baby before they have to bury their baby. They often want to make and keep mementos, such as a handprint or a footprint or a lock of hair. They often want to hold a religious service or ceremony and celebrate the brief life that their baby had. They often may want to create an online memorial and they want to connect with others who have experienced a similar loss. We know that peer support is so, so important to be able to walk this path with others who have gone before them. Next slide, please. Okay, so those are the facts and figures. Now we're going to hear from somebody with lived experience who will tell you about what it was like to actually, lose her baby. So it is a great honor to welcome Kay Matthews with us today. Kay, again, is the CEO and founder of the Shades of Blue Project in Houston, Texas, and has become a voice for many who experience loss, community-based organizations, and it is a joy to welcome you here today, Kay, and to hear your story.
Thank you so much for having me. Hi, everyone. Thank you for that great introduction. I will slowly jump right in. I will always tell folks simply just who I am as a person, because I always want to be seen as the person first and foremost in this work. The work chose me. I did not choose it. And why I say that is because the loss of my daughter was very detrimental to the turning point in my life, just as a whole. As Adrian shared, the emotions that come from a loss, how everything is a trickle down effect to loss. There's loss after loss after loss. And so my birthing experience, I say experience because the outcome is typically what folks focus on, and I was more focused on the experience. It is something that I will never get back. Just like time is the one thing you'll never get back, I'll never get back that point in time that forever changed my life. Oftentimes when we think about loss, we don't think really truly about the magnitude of it. When folks say you'll have another baby and things like that, I think about the fact that I wanted that baby. That was the one that I wanted. And I won't ever get an opportunity to get Troya back. That was one of the things about saying her name. There was a point in time where I couldn't say her name because that was a pain that simply belonged to me. And I did not want to hear her name. I did not want people to ask me questions about her. The thing that I always bring up about loss is that that's very personal. And so if you see someone like myself and others who are sharing this with you, take that as a blessing. That's because we really want to change the way this all works. The morning that I lost Troya was one that simply from time to time plays in my mind like it happened yesterday. I remember the pain that woke me up, that prompted me to call 911 because I literally thought that we were both dying. And there was a blackout moment where I simply woke up to not having a baby and trying to navigate and realizing that this was like a 2-week time period that had already passed. And that the little mementos and things like that, one, I did not get an opportunity to get footprints. I did not get an opportunity to hold her simply because I didn't know that that was something that you did. And so the conversations around loss are just not had when I experienced it. The conversation that was had was that you move on with life. Yet I was so stagnant in that period in time that I didn't know how to move. And so I just knew I was different. And so I was the person that at that time I was fighting for. Although everybody was focused on the loss of the baby, I couldn't even grieve because there's like, you need to go to grief counseling. And I was like, no, I don't want to go to grief counseling because that's tied around the baby. What is happening to me? And so the understanding of postpartum depression and infant loss a decade ago just simply was not there. And so that's where the loss comes in, because I'm so focused on what is happening to me and how my life is spun out of control. That loss was happening around right before my eyes, and I didn't even realize it. It was the loss of friendships, because no one could truly understand, like, why haven't you moved on yet? It's all of the people who kept saying, give it time. And I kept watching the clock because I wanted to know, if you said give it time, you must know when that time is going to happen. And they did not. And so I wandered around, y'all, for almost a year aimlessly, just trying to figure out who the hell I was and who was I supposed to be now that this thing had happened to me. And so I personally never, ever, ever wanted folks to have a bunch of unanswered questions just because people don't feel like you should know. My overall birthing experience in the hospital, it really signified me as a Black woman. I had never felt like a Black woman in America until that the questions. It was the questioning. I questioned the questioning. Like, why are you asking me this? Like, do you have support? My husband was literally sitting right there. Like, who do you think this man is? The janitor? I was so confused by the line of questioning. The amount, the conversation around payment, things like that. I was just like, do you not understand that I just lost my child? What are you talking about? And on top of that, we could pay. That wasn't even a factor. So all of these non-factors were more important to them than they were to me. And then I just remember that time where just having to be like, where's my baby? And no one being able to tell me where she was. And someone having to go and figure it out. Why don't you already know that? So there were a plethora of things that happened in my birthing experience that really pushed me. I hate that, to be honest with you, as a Black woman or Black women, we always have to be so damn strong. It's exhausting. And so in the midst of navigating all of this, I still had to be strong to show up, to do more than exist. And I just felt like this is something that no one else should feel. And so while healing and while navigating the world and trying to figure this thing out, I just simply made an out loud commitment to make this all different. And that I knew that if I was asking why, that was a reason, and that meant that it could be different. I've always been someone who has asked why, even as a small child. Why is this like this? Why does this have to be this way? And so that's been a continuum for me as an adult. If I have to ask why, then there's a problem, and that also means that there's a solution. And we just have to do better when it comes to the things that we have known for years. We have said so many things around loss that don't even currently even make sense if you look at it. And so when you look at someone who has experienced loss in any capacity, there's no one way to lose a child. Let me be clear. And so you don't get to put people in a box and tell me that my story fits over here versus me telling you that it fits right here where I'm saying it does. And so all in all the things that Adrian has shared on the slides around the emotions are true. There are some that are not even there. The biggest one is around shame. Why shame someone? Simply because the outcome was not favorable. How do you think that we feel at that being? So just all of this continues to be something that we have to keep at the forefront. Again, infant loss is typically now it's a part of the conversation. And I'd like to say that I've, played a part in uplifting and continuing to have that as a part of conversations, but we could be doing a lot more. There's so many folks that are out there suffering. And so what I ask for everyone to do is to really focus on birthing experiences versus outcomes. Because when you focus on outcomes, you leave a lot of people out of the equation who need just as much as support as the next person does. And this really all could be different. We have the ability to change these statistics, y'all. These are things that are happening or things that are to happen. So we have the ability to change these statistics. We just really have to care enough to do so.
Yeah. Thank you so much, Kay, for sharing your story. You and I have been in many, many Zoom rooms and in-person rooms over the last several years, and I never heard your story. So I'm so grateful for you to be with us and to put some words around this. And I have heard you say on a couple of occasions, though, that you really felt that you struggled with this difference between grief and depression, or grief and maternal mental health conditions. And I'm wondering if you can just share a little bit more about that.
Right. So grief can sometimes be a construct, right? It's like loss equals grief. That's part of it. But for me, I was the one who experienced maternal mental health because I gave birth. That's the difference. Grief is something has happened, and this is my reaction to it. The maternal mental health aspect comes into play because I gave birth. And so it didn't matter about the outcome. It's just that I was someone who was pregnant and the pregnancy ended in an unfavorable way, but I was still struggling. And so what that did was, by not addressing what was overcoming me, which wasn't the grief was actually delayed because I just simply knew that I was different. I did not even recognize myself. Like that was what was leading the charge, is that I am completely different. And it wasn't because I no longer had my daughter. It's just like I was different. I didn't know how to talk to people. I didn't know how to react. I was struggling in a mental constraint. Like I just woke up a completely different person. And that had to do with the fact that I had given birth, not because I had lost Troya. And so that grief that was delayed didn't happen until like 2 years out of the blue. I just broke completely down. But my husband was just like, I knew at some point it would come because it is expected, right? That it comes within this time frame. Instead of giving people the room to breathe and acknowledging that there are so many things that happen while you're pregnant and certainly in the postpartum period. And we just wasn't making that correlation. But I always wanted to be clear about that because some folks struggle with the fact that I was putting myself first back then. And that was unheard of. It was like, you're not worried about your baby passed away. No, you're worried about her. I'm worried about me because I'm still here. And what do I do with the person that is left? And I didn't want to wither away. It's all of these factors, y'all, that come into play. I knew that if I had did a burial plot and there was a headstone, I would sit there and die a little bit every day, and I would not be here a decade later. So I chose to cremate her so I could take her everywhere with me and still be reminded that she existed. It is all of these things that we go through that are not stated out loud. And so we have these conversations amongst ourselves, and we have to start having them out loud so folks don't feel like they're going crazy by their thoughts and the way that they are feeling because no one is validating them.
Hey, I'm very choked up listening to you. And I know that you're getting a lot of love in the chat, and there's lots of hearts coming out to you. And you're so grateful for you for putting words around this. And so, speaking of words, I'm wondering if there are things that you would have liked people to say to you, or things that you encourage others to say to moms who have lost a baby.
There are a few things. Don't go with the old cliches of give it time or you'll have another baby. That is not oftentimes realistic. There are 3 questions that I ask the folks that come through our organization when it comes to engagement around infant loss. 1, do you want me to listen? Do you want me to listen and react? Or do you just want me to react? And that is giving them back the power that they need from me. And it also gives you an opportunity, the ability to just be and sit with this person, because sometimes we need silence, but sometimes we also need you to be quiet so we can get all of these things out and we want to move forward. One of the things I felt during my time of loss, and even still a little bit today, depending on who I'm talking to, it's the how can I help you? This thing is new. Even when it's not new, even let's say you had 5 losses before, each one of them is new. And so it's new. And so oftentimes we don't know the type of help that we need. But take the extra step to sit down and chat with this person, and maybe y'all can figure it out together. Like that's so imperative. Is not to just be like, well, then I don't know how to help you. If you don't know what you need, then I don't know what you need. And then that's it, right? The effort stops there. It has to be more than that, because I have to figure this thing out. Because for a long time, I certainly didn't know what I needed, but I was clear that I did not need grief counseling at that time because I was overwhelmed and I was consumed. So it was more like an I thing that I was focusing on that was really weird to other people. And so it's that piece right there.
Thank you. We're getting a lot of people dropping things in the chat. I love this one that Joy just put in. She says something like, I'm going to walk beside you and hold your hand. And I love what you said about, do you want me to listen? Do you want me to react? and I'm just thinking I need to take that approach when I talk to my children as well. Now, my adult children, right? When they call and they're, whatever, they lost their job, whatever's going on in their life, whatever loss, right? Do you want me to listen? Do you want me to react? So thank you. I'm going to take that. So the last thing I'm going to ask before we go on to hear some strategies is, you talked a little about some of those emotions, those feelings of shame and blame. And I'm wondering if you can talk a little bit about that, because it really, we've had a couple of conversations about it. And I have to tell you, that really surprised me that that was one of the feelings that you experienced.
Blame is one, because like you mentioned in the previous slides about if your body is designed, like women give birth, right? So how dare you fail me right up into, because I experienced stillbirth. So this was a full-term child who in reality, we made it, we got there, right? We should be good, but that wasn't it. And that's because there's always a focus on outcome. And so the blame comes in is that I failed. I got to the finish line and I dropped the ball, right? And so, but that's also something that the individual who has experienced loss has to work through, or the person or their partner. Like it's an individual effort, and then it becomes a group effort. But it's an effort nonetheless. And then the shame. It's like, oh, I don't have my baby. Are folks judging me because I wasn't able to follow through? And I say that with air quotes because that's the most ridiculous thing, and for folks to make someone feel that way. But it is for fact, whether it's intentional or not intentional, but it's true, and it happens all the time. Those two things, like blaming. Let me be 100%, and I can say that blame is going to be there simply because you do think it's your fault. And then some folks never know why it happened, right? So imagine the stress of not knowing. So some of us get the details of why, this happened, this was the outcome, but some of us do not. And so that blame is something that we carry with us. And even when we know what happened, what if it's something that we feel like we could have done differently or done better? There's still that blame and shame go hand in hand together. And in the recovery process, that's really what you're working through, because it stops you. It stops you from getting up. It stops you from doing everyday things like getting out the bed, eating, talking to people. And so that's the first piece that we're navigating through, is the blame and the shame that this thing didn't end the way we thought it would. And then, like, what do we do next? Like, how do we show up in front of people when they were expecting to see us with a baby and there's no baby and it's just us, right? It's the same though with a living baby. You have a new baby, you show up, everybody wants the baby. And meanwhile, you show up to me, I'm like, how are you doing? Cute baby, how are you doing? Because that's typically the traditional focus, is the baby is here, we got to make sure the baby is all right. For me, it's the opposite. So
making sure the mom's okay. You did point out something about the not knowing, and I didn't have this on one of the slides, but we're working on a fact sheet on pregnancy and infant loss. And one of the things that we articulate in there is that oftentimes there's no known reason for the miscarriage or the stillbirth. And I think that's just, we just don't know what happens, right? Why these things happen. So I think we're going to take a deep breath. Really appreciate Kay for sharing this. Oh, right. So I did want to point out, we talk about this shame and blame and this feeling of that our bodies have failed us. And we even talk about the language that we use around all of this. So for example, we also know that failed infertility treatments, right? There's a lot of grief and loss around that. And we talk about this language of failure that surrounds pregnancy, failure to be able to conceive, failed infertility treatments, the hostile womb, the geriatric pregnancy, right? And then, during pregnancy or during labor and delivery, failure to progress.
Yeah.
And then if the baby isn't doing well, failure to thrive. And this fail, this language that is like so heavy and demeaning and pejorative for women. And so trying to change the language around some of that as well. And we also know that, if somebody has to terminate their pregnancy for medical reasons, or if they were going through an adoption that didn't work out, that there's all of these different reasons for sort of this for pregnancy loss, right? pregnancy and infant loss. So I just wanted to say, you know, we've got this broader umbrella of things that we're considering here as well. Okay, so we're going to shift gears a little bit. Again, thank you, Kay. I think our hearts are just full listening to you and your experience and knowing that we all know somebody who has experienced one of these issues. And so just really grateful for you for putting words around it. So we're going to shift gears here and we're going to start focusing on solutions because Kay and I have been in enough rooms, right? And we're saying we know all the statistics. What are we going to do about it? So I'm next going to introduce Jessica Brooks Woods, who is an expert on focusing on payers and providers and what they can do to help address these issues. So Jessica, I'm going to turn it over to you to give us some suggestions about what employers can do to better support pregnant and postpartum people.
Thank you, Adrienne. I am first completely honored to be here and to have the privilege of being on this board. Kay, thank you for your vulnerability and your strength. It will truly, truly manifest in freeing people, healing people, and helping us all move forward with greater compassion. I come here with wearing many, many hats. And one of the things that Kay mentioned was the work chose me, I did not choose it. It's resonated so greatly with me. Feeling really privileged to be as a Black woman and being alive after having 4 births, and privileged sitting in a place, I believe, of privileged having all of my children survive those births. Yet at the same time, having had experienced postpartum depression twice, one of which the anesthesiologist on the operating table told me I had PTSD. And feeling a lot of what Kay mentioned, blame during those periods of time when I couldn't connect with my child until about 10 months or so. Didn't feel what you saw others seemingly felt with their children. And yet I still feel like I'm in a great place of privilege, having survived many of those experiences. And so when you say it chose me, that's exactly how I feel when I'm having this conversation. So yes, I'm here representing employers and brokers and consultants in the private healthcare marketplace, but I'm also representing a whole lot more. I'm representing my sister who had a miscarriage, and I was there. We knew it was happening, and hours with her, and my niece, my great niece, whose funeral I attended at 21 weeks and of birth. She delivered her at 21 weeks. And then my first cousin and many of my friends who have experienced loss. So I really approach these things with this lens of health equity and consideration. And, you know, coming from the employer place, you know, we often treat and approach healthcare benefits in a homogeneous way with the majority of mind and from a position in a place of privilege. And not necessarily from a place of empathy. And we don't always see individuals, we see a group, we see a collective of employees. And we see women, but we don't see the nuances of race, and we don't see the nuances of family dynamics or socioeconomic status or faith. We don't see those nuances when we design and we create policies, practices, and procedures. And so my perspective on health equity centers on the fundamental principle of inclusivity and conscientious practice, that we're aware that there's no individual or group that's left behind in healthcare. And that we come from that place of we really consider those who are most affected or least considered traditionally in our healthcare system, and we design from that point of view, that we really actually create an opportunity for no one to be left behind and for no harm to be done in what we produce. And I can tell you, working very closely with employers, it's so well-meaning what we, you know, from the employer's perspective, they want to offer many options, many choices in their plans, or new benefits like telemedicine or fertility treatment most recently, and mental health services. It's so well-meaning. But where health equity comes in is that we consider, is my mental health provider inclusive? Are they diverse? Do they understand racial trauma? Do they understand maternal mental health? Do they differentiate that from a broader mental health lens that they take on? Those are the questions that we now should be required to ask and consider when bringing on new vendors and more opportunities for employees to have access to. So know that the current system that's in place, at least from the employer perspective, has been homogeneous, but not with the intention to be exclusive of many others. But we can no longer be okay with good intention. We have to be very intentional about how we approach this, how we not only approach what's in our control as employers, but also who we work with, health plans and PBMs and policy makers and all these folks that surround us. How do we hold them accountable to being more intentional and ensuring that they have principles of fairness and consideration and justice and comprehensive care overall in the design of what we do? So, oftentimes I believe it's looking at this from a place of accountability and looking in the mirror of the roles that we've played in contributing to how things are today, and then facing what we can do. And I think on the employer perspective, that's a variety of approaches, including enhanced data utilization. We look at data, we have access to data. Oftentimes, smaller employers, not so much, but our health plans do. How do we ensure that the data is inclusive of experience? Right now, we look at it in a very quantitative way, but not necessarily a qualitative way. And we're not capturing the stories. We're not acknowledging the experiences within our healthcare delivery systems. And oftentimes, because of that, we're missing so much. And when we look at reporting, we're literally looking at who's pregnant, how many births have we had this year? Did they have C-sections or vaginal births, right? But we're not looking at the dynamics within that, right? And then we're not acting upon it, right? So if we have a certain number of pregnant women, are we looking at how many live births that do we have? And is there a disparity from who we believed we would have, how many babies we thought we would have versus how many babies on our plan that we don't have? No, we're not really looking at it in that way. And I think that's a big opportunity. We must address the enhanced benefit of coverage. I think it's vital to pinpoint areas where maternal care is scarce and inaccessible among our workforce and confront many of the maternal deserts that exist. Oftentimes, we assume because you have a paycheck and you work for a company that you're not in an area where there's a maternal desert. There's these assumptions that if you have commercial coverage versus Medicaid, that you have this greater access, where many of us share the same zip codes. And so as employers, we have to consider that. We have to consider financing digital and virtual care options and facilitating remote monitoring tools. We can say that there's no way and stillbirth just happens or loss of a baby just happens, but there's often times where a mom says something, she feels something might be different, and there's an opportunity to intervene, to monitor, to be heard if she does access the care system, but real time, maybe be able to monitor and then provide that data to her provider if she can't act. Maybe she's in a transportation desert. Maybe she feels like she can't leave work at the time or leave her home or on bed rest for some reason. If we have remote monitoring, I think that's an opportunity for employers and health plans to begin to cover that and think of strategies on how do you identify high risk. I don't think it's in a traditional way we've identified high risk before. I don't know if Kay would have considered herself high risk. My sister certainly didn't consider herself high risk. My niece in her 20s didn't consider herself high risk. So how do we define high risk? And I believe that needs to be informed from the community and those impacted, as well as, of course, from medical professionals. I think ensuring the inclusion of accredited birth centers and healthcare networks. I know many large employers are looking at ensuring midwives are included in network and doulas, but we also need to look at community healthcare workers and who those are and how can we create a level of trust between patients and the care system. And oftentimes that comes from people in their communities who have shared experiences, et cetera.
Yeah. I want to ask a question here about high risk, because I think you identify something that, people could be at high risk, not at all because of who they are, but where they live, right? If they're in a maternity care desert, if they're in a rural area, we hear more and more about birthing centers closing. And so suddenly people are at risk simply because of where they live.
Yes.
Yeah. Yeah.
Yes. Certainly.
Having nothing to do with them physically, but simply because of where they live.
100%. I mean, if you look at most metropolitan areas, there could be a 20-year life expectancy difference, and a bridge separates that.
Yes. Yeah.
And not like the Golden Gate Bridge, right? Like, something that you can walk across separates you being able to live to 65 or 85. And that the environment has a lot to do with that. The political determinants of health and redlining and all of that plays a part.
Yes.
Transportation deserts and food deserts and the medical deserts that exist. And it could be a zip code or two away that determines whether or not you may survive an experience that should be the best time of your life or not.
Right.
But I also believe race and ethnicity, based on what we all know and acknowledge, hasn't traditionally, at least from an employer perspective, been considered. We don't even look at that data. We look at gender, but not necessarily race and ethnicity in our data, claims data and reports that we see. I do think consultants who help employers access this data and employers should be more intentional around how do we do that in a way that doesn't compromise the safety or psychological safety of our employees, to have that lens, but at the same time recognizing that we can no longer ignore that has played a role, and that maybe we have interventions or communication strategies that align with that and helps us to have earlier detection or get earlier prevention opportunities. There's so much I can share, Adrienne. I mean, I have lots of thoughts. I did reach out to a couple of folks that I know in the marketplace that are delivering babies and helping mothers who experience loss in different ways. And one thing I do want to mention that was like glaring to me, which I hadn't even heard myself prior, was addressing disparities by creating access to reproductive endocrinologists. Having those consults be a key part and being covered by insurance. That could be a really significant way for moms who to understand earlier on what their risks are, but also to actually address some of those issues so that the next time they can have a successful birthing experience and a live birth and a healthy baby. And so I thought that was one strategy that I hadn't even heard in the rooms of employers that I think is significant for us to look at, or who's covered, what specialists are covered. And so anyway, I can go on and on. I know.
Well, we're going to come back. Yeah. Well,
sure.
Yep. Let's hear from Jamie.
For the opportunity.
Yeah. Thank you, Jessica. I know there are so many things. It's so great to hear that there's so many things that employers can do and insurance policies, insurance providers in particular can do to better support people who are trying to get pregnant, who are pregnant, and who recently were pregnant for a variety of different reasons. So thank you for all of that. It gives us great food for more webinars. So at this point, we're going to transition over to Jamie Belcito, again, MMHLA's founder. She has been involved in the world of public policy for over 2 decades, and she is going to give us some information about what policymakers are doing at both the national level and the state level to advance policies to support pregnant, postpartum, and bereaved parents. So Jamie, I'll turn it over to you. Welcome. So thrilled to have you speaking with us today.
Love this conversation, Adrienne, Kay, Jessica. Thank you so much for everyone who's here. It is a conversation that needs to be had. We've been having them in our own circles, and we're bringing this together to this webinar here today, and so thankful for the strength and the want for legacy that I think each of us are here for, and that's to use our challenges, our lived experience to change the landscape for other folks to feel heard, be seen, and get the appropriate access and support services that we all deserve. Just want to again say thank you to Kay, who shared such a personal journey of motherhood with us here today. I will get into the policy aspect here. Was very thankful to the person who just dropped the information in on Delaware, unaware of what was happening in Delaware. So this is very great. So we can just start with that. That Delaware has now implemented a leave of absence for bereavement leave when it comes to pregnancy. I'm going to assume any manifestation of what that looks like of loss, and that is exactly where we should be going. So we'll jump right in to this slide after this picture of me that shows me with no gray hair. Okay, so I always feel the more women we elect into office, the better our outcomes are going to be. We are still not at parity by any stretch of the imagination, especially in our state legislatures, although I think New Mexico has over 50% women. The overarching numbers for who's at the helm of leading policy, I think we're at about 18.5% worldwide, and I think at about 26% in the current Congress in the United States. Thank you for the shout out on the gray hair. With gray hair comes wisdom, and discussing how we can positively affect change through policy is something I feel very committed to. These two proposed pieces of federal legislation that you're seeing here, we're uplifting these as this is so important to the conversation. We're going to take a look at the Shine for Autumn Act. The Shine for Autumn Act, maybe folks can give like a little, I don't know, hand clap or thumbs up if they're aware of this legislation. There is a powerhouse named Debbie Hayne who resides in the state of New Jersey, who had a beautiful daughter, Autumn, I think who would be my Hadia's age, so right around 12 or 13 years old. And she took her loss and turned it into policy action in the state of Jersey, which has a lot of focus on maternal and infant health outcomes. And she's taken this legislation to the Hill last session and this session. And this is a piece of legislation that was filed in Jersey, went through the legislature, received a ton of support, is in law now. And now we're seeing this at the federal level to prevent stillbirths through data, analysis, reporting, research. These things seem logical, friends. Sometimes we have to put them in writing. And it's the lived experience and your power of advocacy that puts legislation like this forward. Focus on training for perinatal pathologists. And this allows for those cases that can conclusively show why there was a death within this end stage of the pregnancy, conclusive data. This is needed. This is necessary. And I am so grateful to my friend Debbie Hayne for being able to bring this forth. If she joins us today, she'll speak about this piece of legislation. Maternal and Child Stillbirth Prevention Act, another common sense piece of legislation that would add stillbirth and stillbirth prevention to Title V. We won't get into Title V. Maybe that'll be a later webinar. But basically what it is saying is that monies can be used within our federal programs to help identify why we're seeing an increase in these numbers, how we can de-escalate that, how we can educate, and how we can long-term reduce incidences of stillbirth. Common sense. We shouldn't have to put policies together sometimes for what we know are common sense. However, the power of policy comes to us, and we are able to take our advocacy and issues to the Hill, whether the Hill is Beacon Hill in Boston or Capitol Hill in DC. And we'll move to the next slide, please. Here in Boston, north of Boston, where I live, in the 6th smallest state in the union, was able to take a piece of legislation and file it when I was a legislator last year in the House General Court in Massachusetts, by way of the fierce advocates and moms of Congresswoman Ayanna Pressley and Senator Tammy Duckworth. There was a bicameral piece of legislation filed in Congress. Again, can I just say, because we have moms who have given birth in Congress, we have moms who are in Congress, moms understand what these issues are, aunties understand, sisters understand, nanas understand, and that is the need for pregnancy loss leave. I so boldly took this language, filed this legislation in Massachusetts, 10 days of paid pregnancy loss, of which was pushed back. I'll just share a quick story, pushed back by a white male colleague who was an attorney inside the State House, who said, we don't need this. We already have this. We actually don't. Well, you could use family leave. Sometimes you can't. You could use the traditional bereavement. You know what? My own personal miscarriage took more than 3 days, and I ended up in the hospital hemorrhaging. So kind of needed a little bit more access than those 3 days. I use this tongue-in-cheek approach to say, we know what we need, and we're going to continue to bring our issues to the halls of our legislatures and ask them to do the right thing. So this is just a quick overview of what this pregnancy loss looks like here in Massachusetts. And I am hopeful for a bill like this to go through our Commonwealth. It's always lack of political will when you don't see these things move. So lean on those who you're electing into your halls of whether it be federal or state, city or select board. You deserve to be heard. These are low-hanging fruits, and until someone comes up with a different way for us to bear progeny, we are the ones doing the work, and we deserve to have the support that we need. And it's also bringing in the spouse and domestic partner who absolutely suffers their own challenges and grief in these processes. We'll go to the next slide, please. State and local legislation. There are already states who have taken this issue on. Jessica Brooks Woods spoke about the employer part, which we're seeing more and more employers taking this on. Young parents, women in the CEO positions, HR, young dads. We know that we need to support our employees. States also have that ability to say across the board, we are going to implement bereavement leave for any parent who is dealing with any sort of challenge, whether it is loss of a child through stillbirth, a miscarriage, any negative outcomes on adoption or failed surrogacy, you name it, we need to be supporting parents. Oregon put forth what I believe to be the most comprehensive bereavement leave act. It's talking about 25 plus employees offering 2 weeks of unpaid bereavement. In the next slides that we'll have coming up, I've put the link in there so that we can do a little bit more research. It seems to me as if from day one, even if you're self-employed, there are some benefits of eligibility here. We do want to be equitable. Every individual should be able to obtain bereavement leave. It shouldn't hinge on the fact of whether or not you're working for a small employer. And if you aren't, you can't take that leave. Illinois just enacted the Child Bereavement Leave Act as well. And again, there's always, right, we here in the United States, we're always put numbers and business and money first. At least that's my interpretation of the game. And so we're always putting some qualifier there that's palatable for particular groups to sponsor these sorts of bereavement leave acts, but it's a step in the right direction. It's always the tip of the iceberg, and we are seeing that more and more states are putting these forth. Again, citing my dear friend in the chat who put Delaware out there. Massachusetts has one pending, and I saw California did as well. Thank you to Jose Ortiz for putting that information on Illinois in the chat. Cities. Why, yes, your city council members are able to address these issues. Washington, D.C., Pittsburgh, and Portland, Oregon have put these policies in place. Washington, D.C. is seemingly very progressive. I do have to give snaps to that council who has done everything from addressing maternal mental health to maternal mortality and putting 2 weeks of paid leave for loss of a child under 21, including stillbirth. Pittsburgh, I'm citing the city's accomplishment here, that city council, 3 days of leave for miscarriage or pregnancy loss, either parent. Although I will say our fierce board member, Jessica Brooks Woods, pointed out that there were some caveats to accessing that leave, and we should dig more into that. In Portland, Oregon, 3 days of paid leave for miscarriage or pregnancy loss, and then we'll point back over to the states that Oregon actually has a state law as well. So moving in the right direction. We'll go to that next slide. These points here are really drilling down into what that Support Through Loss Act, which goes into effect January 1st. Okay. Let me back up and saying, great, the state did this. And then when does it come into place? It comes into effect January 1st. Requires employees in the state to provide 2 weeks of unpaid leave. Another issue. We can get into the details of that at a different webinar. Again, tip of the iceberg. We need to make sure that people are compensated, especially during these times of loss. But for now, here's what the state did here, identifying these issues here: miscarriage, unsuccessful round of in uterine insemination, reproductive assistance, failed or non-finalized adoption, failed surrogacy, diagnosis affecting fertility, and stillbirth. So this is also equitable to the partner, and that is a move in the right direction. We'll go to the next slide. In Oregon, again, this is not as comprehensive per se, but I think it was done a little bit nebulous in order for individuals to access. It went into effect, the Oregon Family Leave Act, with specificities around pregnancy loss and child loss. These little blue links, and the last one too in Illinois, when you get the slide deck, you're going to be able to click on those, on the blue part, the header, the title, and delve into the details on this. And we'll head to that next slide. Is this where I conclude? Because I do have a few other thoughts before.
Yeah, go ahead, share your thoughts, and then we're going to switch over to resources. Yep.
Okay, wonderful. Use your voice. That's how we're here. I'm the founder of this organization by way of my own lived experience, having had a 3-month miscarriage and not being taken care of appropriately. I was sent home to have a medical abortion at home, of which no one followed up with my health, and ended up hemorrhaging about a month and a half after that out in the driveway of my home. And no one deserves to be treated like that. I was afraid to talk to my employer about it. I was afraid to talk to my spouse about it, my family. It was very much overlooked. We cited the discussion Adrian and Kay and I had around the shame. I say this with tongue in cheek, but I think a lot of our religious influences in at least where I grew up, made it an issue not to be talked about, that it was God's will. And yet somehow or other that didn't really seem to make that any better for me. I was very excited to meet a child that did not come to fruition, and that really gave me quite a lot of PTSD, the way it was handled. And when I went into my next pregnancy, of which now my daughter's 13, and on her way to Washington, D.C., friends, because that's what 8th graders do sometimes, is go on a trip to change the world, is it absolutely made my next pregnancy of advanced maternal age, another area we brought up here in this discussion, how we talk to women, how we frame their pregnancies. You already had a prior miscarriage. You most likely will have complications going into your next. It's not good enough. Use your voice. We are all here to change the world. I truly believe that, and each voice can do that. So thank you so much for joining us today. So thankful for the space, and so grateful to MMHLA for bringing everyone here together today. So with that, we'll head to the resources, and thank you all so much.
Awesome. Thank you so much, Jamie. And it is really great to see legislation happening, right? We can mandate some of these things at the federal level, at the state level, at the local level. It's really exciting to see cities taking this on. So we're going to transition to some resources because, of course, we always want to make sure that we give people information to move forward. So here are some excellent resources that address pregnancy loss, stillbirth, infant loss. In particular, we want to shine a spotlight on Return to Zero Hope. And in fact, we have with us a staff member from Return to Zero Hope. We're going to actually, we're just been texting with her and slacking with her, see if we can get her to come forward and share resources. If we go to the next slide, which focuses on RTZ Hope. I think Anna is with us. And while my colleagues behind the scenes try to bring her up to elevate her to the speaker, RTZ Hope is an organization led by our good friend Kylie Hanish, offers a support for both bereaved parents and for providers who work with bereaved parents. And they do all kinds of awesome things for bereaved parents, including things like in-person healing retreats. So last week I was emailing with Kylie. We were working on our fact sheet and she was contributing to it. And she's like, I'll get back to you. I'm getting set to go on a retreat. So lovely way to help parents heal from their great loss. And just seeing also the chat things fly by. Don't forget about the grandparents as well. Absolutely. So Anna, go ahead, is pinned and can speak. Anna, do you want to tell us a little bit more about what RTZ Hope is doing?
Sure, thank you so much. I'm happy to be here representing both my own organization, Gifts from Liam. I'm the founder and executive director of Gifts from Liam, and we're based in the Chicago area. But I am also here wearing, I think, as Jessica had said, many hats, right? So I am also a support group facilitator for Return to Zero Hope. And I have served as a facilitator for both the people of color and the brand new Spanish speaking support group. We just started our first Spanish speakers group this past Sunday. So we already have our upcoming groups on the schedule, which you can find at rtzhope.org/register. Please share all group opportunities with your participants, with your clients, with the families that you're serving. We at RTZ try to focus on addressing the unique needs of different populations. And so that's why we do have a people of color support group, a Spanish speaker support group. We have groups for TFMR. We have groups for LGBT, because we recognize that within each of these diverse populations, there are those unique needs that need to be tended to. As Adrienne was sharing, there are also retreats, which take place for the most part in California. Definitely would encourage you to check those out. And then there are lots of resources on the website for providers and for families. And the resources are available in English and Spanish. So for providers to help learn and understand how to better support families after a pregnancy or infant loss, and for families to help to better understand how to navigate that process. Okay, I think that's a good recap kind of RTZ Hope. And it all started, I don't think you mentioned this, but it all started with a film that Kylie Hanish and her husband produced, the Return to Zero Hope film, which is a really amazing resource for learning about the experience of going through a stillbirth. And I'm happy to answer any questions about RTZ if anyone has any.
Oh, thank you so much, Anna. So grateful to you, to Kylie, to all the moms who are using their lived experience, all the parents using their lived experience to help others. I do also want to highlight Postpartum Support International, which has also a lot of resources for pregnant and postpartum parents in general, but also for parents who have experienced a loss. So I'll just put up that slide again. Lots of questions in the chat with different organizations that are other resources. So we'll try to collect those and share those as well. And then I think we are just about tying up. Were there any, we've been going through the Q&As, making sure that we're sort of addressing things as we've been going along. One question about how do legislatures define child? I think each one is different, but good to see that some of them are recognizing pregnancy loss, including miscarriage, and they're spelling it out, including miscarriage. Okay, so so grateful again to everybody who is with us today. Big round of applause and big hugs to all of our presenters. We have a quick poll for all of you, which we're going to launch. Basically, just one or two questions. Did you find this webinar informative or helpful? And then afterwards, we will send, as I mentioned earlier, we will be sending out information to everybody who participated today. We'll send you the slides, the link to the webinar. It will all also be posted on our website. We'll have a feedback survey so you can help us continue to improve. I always ask for other topics that you'd like to have presented. So one of our goals at MMHLA is to provide information that uplifts the entire field of maternal mental health. So if there are specific things that you'd like us to cover, we are happy to hear that. Again, we are so grateful to all of you for taking time from your busy day to be with us, to share your experiences, your expertise, your knowledge, your resources. This has been a terrific learning experience for all of us. I'm so thrilled to see all the chats, the thank yous, the hearts, the hand claps, the thumbs up. Wonderful speakers. Thank you all for helping us delve into this particular topic of maternal mental health. Yes, so you'll also be getting all of those resources. And here, we'll leave this up for a minute or two if you want to follow us on social media, as well as Jessica Brooks Wood's organization, Kay Matthews' organization, Shades of Blue Project. Follow us on social media. We'll send you information about other webinars. We hope you'll join us in November. And one more shout out to our funder, California Healthcare Foundation. Thank you to them for supporting this webinar series. And please check out our website for all kinds of additional resources. We actually have spoken longer than we thought. I think we've answered as many of the questions that have been posed in the Q&A, uplifted a lot of the information from the chat. And so we are going to end on time and let all of you get back to the business of the day. So thank you again. And we look forward to seeing you in November. Have a great rest of the day.